Hi everyone, welcome to the presentation on nephrotic syndrome as part of the specialist area of paediatrics. So a few questions to get you guys started and thinking about what we're going to cover. Question 1. Nephrotic syndrome occurs due to damage of renal collecting duct, glomerulus, distal convoluted tubule, or the renal medulla. So if you think about the symptoms that you know that the nephrotic syndrome produces and how damage in each of these areas could cause it, so which one's most likely? So it's glomerulus, and here's a little recap of the kidney nephron. And as you can see, the glomerulus is here, so it's sort of filtration of the blood into the nephron. Question 2, what is the maximum size of a protein that can fit through a healthy glomerulus? So protein is measured in Daltons, and it's a pretty hard question, but yeah, good to know. So I've asked this because this is a concept of nephrotic syndrome. So in glomeruli damage, proteins larger than this are able to pass through into the urine. What is not a cause of nephrotic syndrome? Lupus, liver failure, sarcoidosis, or minimal change disease. So this is what is not a cause. So one of these presents the same but is not a cause of glomerular damage. So it's liver failure. So it can present the same along with heart failure, and that will be a differential that you think about. So nephrotic syndromes, this is what we'll cover today. Going through describing it, symptoms and history, investigations, differentials, and clinical examinations. So what is nephrotic syndrome? It's a collection of symptoms due to the damage of the glomeruli. So note that it's a syndrome, so it's not actually a disease in itself, it's caused by an underlying disease. So syndrome is a collection of symptoms. Okay, so it's characterized by high levels of protein in the urine with low levels of protein in the blood because it's all getting filtered out of the glomerulus. So the damage of the glomeruli can also be termed glomerulonephritis, which we'll see in a bit. Causes split up into primary or secondary, and these causes could be focal segmental glomerulosclerosis, or things like diabetes and lupus. So we'll go into how we'd break them up and how they would cause nephrotic syndrome. And it's more common in boys than girls, and primary nephrotic syndrome is usually diagnosed in 2 to 5-year-olds. So primary, this term means that the disease is limited to the kidney, whereas secondary, the condition affects the kidney and the rest of the body. So secondary is things like diabetes and lupus, whereas primary is things like focal segmental glomerulosclerosis. But we'll go into this in more detail. So inflammatory damage means the glomeruli are leaky, and the proteins larger than 40,000 Daltons, as explained in the past, are let through the glomerulus. These proteins include albumin, antithrombin, and immunoglobulins, so this can result in the symptoms that you'll see. So cause of nephrotic syndrome, this is a bit about the primary and secondary definitions. And as said, nephrotic syndrome can also be termed glomerulonephrosis. So the most common cause of primary nephrotic syndrome is minimal change disease, and this presents in children. So you'll be thinking about this differential if it's a child presenting. This is different to the most common cause of primary in adults, which is focal segmental glomerulosclerosis. So minimal change disease, this is when the changes are so small they can only be seen with an electron microscope, and it's considered idiopathic for the moment. They're not really sure what causes it. Risk factors can be infection in pregnancy, compared to focal segmental glomerulosclerosis, which is sort of tissue scarring in the glomeruli, and some causes of this one can be previous kidney injury or morbid obesity. The causes of primary glomerulonephrosis are a diagnosis of exclusion. So first of all, you want to rule out any cause of secondary glomerulonephrosis, and that's what your investigations are based around. and these are diagnosed only by biopsy. Okay, so these are a few pictures. So this picture is a normal glomerulus surrounded by the renal tubules, and this one shows diabetic glomerulosclerosis, which is the main cause of secondary glomerulonephrosis in adults. So some renal genetics, this is important to be aware of. Recap, if a child does not show signs of a systemic disease, and therefore by exclusion is suggesting a primary glomerulonephrosis, then it is most likely to be minimal change disease, as discussed before. However, this treatment involves corticosteroid treatment, and if the child is resistant to corticosteroid treatment, which is described as no remission after 4 weeks of 60 milligram prednisone, you've got to think about these steroid-resistant nephrotic syndrome or the hereditary nephrotic syndrome. So these are more genetic causes. So nephritic syndrome, this is slightly different but can be confused. So nephritic syndrome is when there are red blood cells in the urine, and these are not present in nephrotic syndrome. It may also involve hypoalbuminemia, which you see in nephrotic syndrome as well. But the main difference is that there are red blood cells in the urine in nephritic syndrome. So the causes, so in children, these are some causes, the most common being post-streptococcal glomerulonephritis, whereas in adults the causes are slightly different. And as said, glomerulonephritis is quite a broad term for the inflammation of the glomerulus, and glomerulonephritis can either result in nephritic or nephrotic syndrome. But as said, post-streptococcal glomerulonephritis is the most common, and it's treated with anti-inflammatory and antihypertensive medication. A good way to remember this is nephrotic has an O and so does proteins. So nephrotic is where there's leakage of proteins, and then by exclusion you remember that nephritic is the one where red blood cells leave in the urine. So some symptoms and signs, these are the main things you've got to look out for. So protein in the urine, low blood albumin because it's all going out in the urine, high blood lipid levels, and edema. This could show as eye puffiness, pitting edema, pleural effusion, so breathlessness, and ascites. So there are some others to be aware of as well. Weight gain, this is due to the edema. Foamy urine, due to the protein in the urine, and feeling tired. And some complications to be aware of are blood clots, infections, and a high blood pressure. So to go through each one, proteinuria is due to the leakage of proteins through the glomeruli, and as a result this means you have low blood albumin. The high blood lipid levels is because the low albumin levels in the body stimulates protein synthesis and therefore results in overproduction of lipoproteins, and lipid breakdown is also decreased because of this, so you get a build-up of lipid levels. And then edema is due to this low blood albumin because it reduces the oncotic pressure in the blood and therefore the water collects in the interstitial tissues. And then I've explained these as well. Infections, also one to note, as mentioned earlier, immunoglobulins can also leak out into the urine, so because you have less on board you're more likely to get an infection. Okay, so some things you want to ask about, and it's mainly trying to find an underlying cause, because as I've said, you want to rule out secondary glomerulonephrosis before thinking about primary, because secondary is a lot more common, it's easier to distinguish, whereas primary you need a biopsy. So yeah, you want to find the underlying cause. So diabetes, glomerulosclerosis is very common, and if it's undiagnosed, I put some things you want to ask about to try and find out whether they have it and to diagnose it as well. Some of these are quite rare but important to think about and good revision to go over sort of the symptoms you'd see. Sarcoidosis, it can affect any body system. It's where you get accumulation of granulomas, and this is most commonly in the lungs, skin and lymph nodes, hence why you get some chest pain and wheezing and then lymphadenopathy. Okay, so investigations. You do urinalysis, and this would be a 24-hour urinalysis. You're looking for those proteins in the urine. You want to do a comprehensive metabolic panel, which will look for the low albumin levels. Creatinine clearance test will assess the glomerular filtration capacity, which is really important to assess the function of the kidneys and the glomerulus. The lipid profile is to look for the high levels of cholesterol, specifically LDL. And then kidney biopsy is to try and find a primary cause if the others have been ruled out. So main differentials are heart failure and liver failure. This is mainly due to the most prominent symptom of nephrotic syndrome being edema. So heart failure, to try and distinguish this from nephrotic syndrome, you'd look for cardiomegaly, raised JVP and heart murmurs and things like that. Whereas liver failure, you'd be looking for jaundice, Kappa-Medusae, pruritus, enlarged spleen, spider nevi, bruising, and abnormal LFTs as well. So treatment, you want to treat the underlying cause. So for example, if the patient has diabetic nephropathy, then you want to get on top of that and the blood glucose level to try and reduce the kidney injury. And then it's basically symptomatic treatment. So you want to do ACE inhibitors for the high BP, diuretics, medical nutrition therapy. This is to sort out the hypoalbuminemia and the hyperlipidemia. So limiting fluid intake as well to sort out the edema, and then corticosteroids for kidney damage. And in general, it's a good prognosis, but then again, this depends on the underlying cause. So clinical examination. So you want to look for edema and pleural effusion as well. This can be quite a bad complication of it. Secondary glomerulonephritis, you want to look for these. Remember, you want to rule out secondary before you move on to primary. And then, as I've just discussed, you want to rule out the differentials to make sure it's not these as well. So some OSCE tips. So this is what I think may come up, or you may be asked in terms of nephrotic syndrome. So interpreting a urinalysis, you want to see if the urine is frothy, because this is a really good sign there's proteins in it. And if there's only raised protein and no other signs of infection, so no other white blood cells, then you could be thinking nephrotic syndrome as a differential. Comparing nephrotic to nephritic, then you'd want to look for blood in the urine, and then that would be nephritic syndrome if there are both. If there's just protein in the urine, then it would be nephrotic. Also, full blood count interpretation. If there's low albumin and high lipids, then you'd be thinking nephrotic is a differential. Taking a history as well, asking for the symptoms as I've just discussed. And then maybe interpreting a histology slide of glomerulosclerosis, but that would be pretty tricky. So in summary, what have you learnt? So just go through these questions again. So it's a damage of the glomerulus. And again, pause this slide and just refresh your memory of the diagram. And the size that a protein can normally fit through a healthy glomerulus, and what the size above proteins can fit through in nephrotic syndrome is 40,000. Sorry, that one should be highlighted. So it's 40,000. Okay. And final question, what is not a cause of nephrotic syndrome? So as discussed, liver failure presents similarly, and you want to try and rule out because it's quite a strong differential. And these ones cause nephrotic syndrome. So minimal change disease if it's a child presenting with nephrotic syndrome, and then sarcoidosis and lupus, you want to look for symptoms of that to rule those out. Thank you for watching, I hope it helped.